This week on the BackTable podcast.
Why not listen to how others have done it and approach these really practical considerations outside of just like the data that we see at a conference, the overall survival, the hazard ratios, all of that. Let's actually talk about how to get the product to our physicians and to patients. Those conversations are not happening at conferences. They're happening at creator weekends, though. It's not enough to just publish, share data, talk about breakthroughs. I'm a big believer in access to care, as you know, and I think access to care is really that last 10% of how do we actually get that new development into a clinic office, into the operating room. And that's where I think, BackTable and these creator weekends really have the opportunity to disseminate education in a way that we have not done before.
Ruchi.
Anish.
Dr. Talwar.
Always great to chat with you.
Yeah, same. You're coming off this great creator weekend that we did over there in Nashville. How was that?
It was awesome. I think Creator Weekend is just such a unique way to get all of our experts in urologic oncology as it relates to, what I do together in person, great vibes, really interesting, practical conversations, and just a good time.
What was like a highlight from the weekend for you?
It was really everybody, all of the participants of the Creator Weekend talking about what a great experience that they were having. They bring their families along. They have time to explore Nashville, which is a great city. I'm biased. And at the same time, we get together outside of the rigidity, the formality, and the stress that conferences often bring. It's low key. We get together. We have conversations that are really centered on the day-to-day inner workings of seeing patients, providing excellent care, doing complex surgeries, taking care of cancer patients, and we learn from each other. Most importantly, I listened into the recordings even if I wasn't participating in them, and everybody said, wow, I learned something today. Even though I was the one here speaking, I learned how one of my colleagues does something, or I learned about a different way to approach a complex problem. So that's really a highlight for me.
How come this isn't happening at a conference?
It's hard. Conferences are jam-packed with not only back-to-back sessions, you're in a formal setting where there's folks sitting on a stage, everyone else is in the audience. I don't know that we're able to have these nuanced, nitty-gritty conversations. You have limited Q&A time. You're usually using a slide deck and sticking to an exact topic that a moderator of a panel wants you to cover. And it's a lot of fatigue, right? You're there for 3-4 days. Some conferences are 5 days long. By day 5, I'm ready to get back in my own bed, eat some non-hotel food. You don't kind of have some of those constraints with a creator weekend.
It's interesting you said you learned something. What do you feel like you learned? What are some things that you came away with?
So just more broadly, I'm going to speak to what I learned from these creator weekends outside of one specific topic. There are a lot of ways to approach the same problem, and we are all constrained as physicians by the settings and the practices and the hospitals that we are in. And so what I love most about these creator weekends are the ability to brainstorm and maybe share different learnings that other urologic oncologists have had dealing with some of these problems. For example, in the NMIBC space, there's a lot of new products that are coming out. It's not always easy to get these products approved through our various committees and hospitals, and it's not always easy to figure out workflows to give a $250,000, $300,000 drug in the clinic. It might require us to do a procedure with it. We might need to figure out how we allocate specific rooms for this, staffing. And so why not listen to how others have done it and approach these really practical considerations outside of just the data that we see at a conference, the overall survival, the hazard ratios, all of that. Let's actually talk about how to get the product to our physicians and to patients. Those conversations are not happening at conferences. They're happening at creator weekends, though. And so it's not enough to just publish, share data, talk about breakthroughs. I'm a big believer in access to care, as you know, and I think access to care is really that last 10% of how do we actually get that new development into a clinic office, into the operating room. And that's where I think, BackTable and these creator weekends really have the opportunity to disseminate education in a way that we have not done before.
So that last mile or last 10%, I mean, I guess dumb question is the layperson like, hey, a drug comes out, here's the indication, and there's even some guidelines on when you use it. What more is there to know?
Some of these drugs are not just pills, right? They are devices that need to be put into people's bladders. So who's telling you, well, how do you actually get the device, through the cystoscope deployed into a patient's bladder? Does the patient need antibiotics for this kind of procedure? Does the patient need sedation? Can it be done without sedation? What are the side effects? I don't want to hear from necessarily the drug rep who is representing the drug company. I want to hear from my peers who deal with the actual side effects of this drug or this device. What are their patients saying? How do they have these discussions? And that physician to physician trust and learning is just something that I think doesn't always exist in other forums. And so that is what I think is most unique here. It's not really just what's on the package insert, what's on the website. It's some of those more granular, nitty-gritty details that we have the ability to share with each other.
Well, I mean, this relates to what I wanted to talk about, I guess. But so let me back up. How many years out of training are you?
I guess 3 now.
The big 3.
Time flies. Yeah.
Time does fly. Is there a big difference in your day-to-day from being, quote unquote, in training to being out of training?
Oh, yeah. And let's take that a step further and actually talk about big difference in my day-to-day from when I was just out of training, right? So let's say year 1 versus now. Year 1, I was so hyper-focused on following every single guideline and making sure I knew all the evidence. And again, making sure that I was doing the right thing. By year 3, you realize the right thing is really different for each specific patient. It becomes so much less about that guideline or that, clinical pathway. And you really understand what is important to that specific patient in the exam room who's sharing their quality of life concerns or their priorities or what is most important to them. And so it's I really like that year 3 stride. I know the pathways in and out. I know the right thing to do, but it's developing that special relationship so I know when to do it. It's not always the right answer to operate on someone or to give them the drug. It's very, very patient specific. And with time, you have that experience and that confidence that comes through conversations like the ones that happen at Creator Weekend, where I hear about people maybe doing something that is different and may not be out there in the literature, but I think is a really great idea.
So does it happen as a urologist that you are asked to say, do a procedure or prescribe a drug, provide some kind of treatment that you either haven't done since training or maybe you've never done before, or, you just don't do that many of?
Oh, yeah. And, let's talk about call. Because when I'm on call, it doesn't matter that I've done a specific fellowship in urologic oncology. I am covering all general urology, any urologic problem that walks through the door. So it could be some complex reconstructive surgery. I mean, I'm telling you a true story. This happened to me. I'll spare you the gory details because, again, a urology on call is the stuff of nightmares sometimes.
Yeah, seriously.
But
hope I'm never there.
Yeah. But I had to do a very complex procedure that I had not done since training. And at the time of training, I did it, autonomously, but I had the supervision of my attending. I was a chief resident. I did the case, but my attending was right there watching over me, making sure I was doing everything right. And lo and behold, it's me and a resident now. And I'm the one making sure everything's going well, right? So there are a lot of instances where we are doing things that we may not be super, super comfortable with.
I'm guessing patient comes in, it's probably the middle of the night or some random time. How much prep time do you have for that?
Not a lot.
Seconds, minutes, hours?
Practically hours because, listen, I get the phone call, right? And I need to get into the hospital.
You're at your house.
I'm at my house. I get the call. I got to drive in. And then let's say I see the patient. Then I determine we need to go to the operating room. I wish things were like this, but they're not, right? So we got to get the patient ready for surgery, transfer them to the pre-op area, go through our checklist, get them in the operating room. So let's say that takes an hour. That's when I'm YouTubing how to do X.
So you get the call and, as you're waking up at 3 a.m., you're like, okay, I gotta go figure out what's going on because I might have to do this procedure, which I haven't done in a while, or it might be fine and I don't have to do anything or whatever. And there's some in between. So you're already thinking I have to maybe do this procedure. Were you like starting to look it up on the way, in from home or like texting people?
Yeah, all of the above. So middle of the night, probably not texting people, although I do call my reconstructive urology colleague at all hours because I'm like, I got to talk to someone about this. So his phone is always on. But I actually keep a Google Drive of my notes from residency in my phone at all times. And I will often reference those notes that I took when I was a resident. At the time, I put pictures in there from our textbooks. And I will also often, after I review those notes and read them and look at those pictures, I will look at videos. So there's a variety of places to access surgical videos. YouTube is one. I was not joking when I said YouTube. There are a lot out there. And the AUA, it's the American Urological Association, also has a video bank on their website. And so I will often watch that video as a quick refresher if I'm doing, for example, a priapism shunt or some kind of other, emergent procedure I haven't done for a while.
So is YouTube number one and then AUA Video Bank is number two?
I think so, because YouTube is just easier to search. AUA requires me to log in. Sometimes it doesn't load right on my phone, whereas YouTube is really easy to access.
Are there other video sites you go to or other places you look?
Those are my two. If I need more detailed visuals, then there's this atlas, Hinman's Atlas of Urologic Surgery, that I will look at diagrams and step-by-step instructions of procedures. Kind of annoying because I have to log into my Vanderbilt library to access the book and, then pull it up. But that would probably be number 3. I've taken some of those and put them in my notes though, so.
I mean, aside from call, does this sort of thing happen?
If I'm doing a procedure I haven't done in a while, and particularly as an early attending, if I was doing something I hadn't done in a while, then I would go back and look at my own notes. The other thing I'll say is I also will look at my own surgical videos. So if I had a case, a really complex partial nephrectomy that went super well, it was a really tough case. It went really well. I will often go back and watch that video to see what I did to set it up well. I'm not perfect, and there are cases that also sometimes don't go so well. And so the reverse is also correct, where if I have a case that didn't go well or there was some issue or some complication, I will go back and watch my own surgery to make sure I can identify what went wrong, what I should do differently next time.
How do you have the footage of all those procedures?
Our hospital has the ability to record all of our robotic surgeries, and I do a lot of robotic surgery. So that's the way I audit my own robotic techniques. But we also have cameras that are available. At some hospitals, they're in the light handle. And so you can set up the light handle when you're doing open surgery to record the case. Another thing folks are doing, especially now, is using metaglasses and recording their own surgeries using metaglasses. So I think that's great. Good reminder.
Come on, Ruchi. Come on.
Yeah. Well, my bias is I'm a robotic surgeon, so primarily. And so most of my stuff gets recorded that way. But there are a lot of my colleagues out there who do way more open surgery than I do, and they use those metaglasses.
So, I mean, do you go and look at your tape regularly or just as a part of preparing for something?
When I was in my first 2 years, I reviewed my own game tapes religiously. Now I review it if something went really well or if something didn't go so well. So I'm not as diligent about the day-to-day, but in my first 18 months to 2 years, you bet I was watching a lot of footage.
Are there other things that you do, more generally, for keeping up with whether it's new devices, new drugs, new ways to use those, Is there a constant wave of stuff?
There is so much. There is constantly so much coming out, so much to keep up with, so many new techniques. And so I really leverage the community that I've built, both online and, via text message, like you alluded to earlier. But I listen to podcasts all the time. Obviously, I listen to a lot of BackTable, but I also listen, to be fair, I'm going to be unbiased here. I listen to there's not that many other podcasts per se out there, but I do come across other like videos people are doing, articles people are tweeting or posting on X, I should say. It's no longer Twitter. They're posting on X. This is going to be a bit of a tangent, but it's kind of sad what has happened to Twitter/X. It used to be my one-stop shop for everything urology. Yes, it was amazing. Like, it's how I kept up with new articles that were coming out. People were constantly tweeting. It was almost like they were constantly writing editorials in the form of these tweetorials of these new techniques, new topics, all that. X has become a bit more toxic in general. Rhetoric, I think, over time has become a bit more toxic. So I'm not logging in as often. But, there's Blue Sky, there's X, there's Facebook groups. Then there's like good old fashioned conversations with people that we have at these conferences, meetings.
You just limit all of your social activity to True Social now, is what you're telling me?
Oh, yeah. You know me well. I'm sure you see me on Truth Social, right?
I do regularly.
Yeah.
I couldn't resist. So, but let me go back to how it was during the heyday of, urology Twitter. So what were people putting on there?
God, everything. Articles they were publishing, articles they read that they thought were interesting, videos of their own surgical techniques, sharing hard cases. They would post imaging of like a tough case and crowdsource and like put polls out there. Who would do this? Who would do that?
Really?
Yeah, it was awesome.
When was this? When was that happening?
I mean, when Twitter was still titled Twitter, I think it was that entire time. I'd say towards 2022, maybe 2021. 2021 onwards, things slowly started going downhill.
Like, what does that mean? Like, what happened? What, I guess people just stopped posting, or
no, the algorithms changed. So I was no longer seeing only who I follow, right? I started seeing a lot of other content. I guess because the algorithm was probably favoring like paid accounts or advertisements. If you think back, there weren't that many ads on Twitter. It was really just like who I'm following. I had a really well curated timeline, I'll call it. And I was very happy with what was popping up on my feed. As time went on, somehow like more advertisements started coming up, more paid accounts, more trolls, some fake accounts, lots of political rhetoric, lots of not pleasant things being said. And so I didn't really want that negativity. And I think others didn't either. So you still do have a small group of really vocal people online, but it is significantly less than what it used to be.
So it wasn't so much that people stopped posting, it was that you got served other things and there was way more content in the stream. And so you're like, all right, well, this is not the kind of high yield activity that it used to be.
Right. So for every one urology post, there may be 5 or 6 other advertisements or political articles or trolls like commenting on people's, there were like, you would post something about prostate cancer and then there'd be people attacking you like prostate cancer is not real, like this is a pharma, like, conspiracy, we should have cancer cured, but everyone wants to make money. And you're like, okay, I like work really hard to take care of cancer patients. Like I can't see this on my feed. Doctors are
crazy.
evil.
Yeah, right. Wow. That one will allow. So I guess I like to ask this question. For you, is like the constant wave of new information, is that like a boogeyman you're trying to always keep ahead of? Like, I got to stay ahead of this? Or you're like, it's there, but like, I'm fine,
I think when you're starting out, it feels really overwhelming. So it's more of the former that you mentioned, especially in my first 2 years. It's like, wow, I am like still getting my head around everything I've learned. And now I need to learn all these new things and I got to keep up with all the data. And once you get in a flow and you really understand the foundation and you're good at taking care of the bread and butter, that's now when I find all of the new forthcoming information interesting, stimulating. I want to learn about it. And it's gotten so much better because I can stream a podcast when I'm working out or driving. And so I can like take these tasks that were otherwise probably wasted time and make them productive. I don't mind running if I can, learn about a new product in NMIBC while I'm running. It's a great use of my time. I'm getting exercise. If I'm stuck in Nashville traffic, which is really a bear and happens quite often, I feel less frustrated because I'm like, you know what? Let me listen to this BackTable episode on XYZ and I'll stream it and it'll be a better use of that time.
How do you think this will change as you get to 6 years, 10 years out? And related to that, rather than having like panicked or whatever, trying to, keep up with everything, you're like, okay, I got this flow of, I keep up with this, I do that, you've got your stream of learning, let's just call it. Is that typical?
It's hard for me to say. I can't speak for everyone, but in my circles and my network of mentors, as well as people I may be mentoring, so like I'm in the middle, there's people above and below me. I think most people have their trusted sources that they use to get content. It depends on what kind of a learner you are. There's a lot of people who are not audiovisual learners who need to read. And so those people might be the ones who are still subscribing to those journals that get mailed to you and they read them and that's how they keep up with things. I think the younger generation is certainly more audiovisual. We also have limited attention spans. The world's a different place now compared to how we used to learn. And so those are the people who I think really appreciate the podcast. I talk to trainees all the time who are like, I love BackTable and other podcasts, the AUA guidelines, app they have. There's like other AUA podcasts out there. They use those to keep up. They use those to study for their in-service or for their boards. And so I think most people do keep up. People can't just put their head in the sand because remember, as physicians, we need to keep up not only to take care of patients because patients are very well informed. They come into our offices and they say, are you offering X new treatment? I read about it. I saw it. Like that's the world we live in. So you need to keep up. But people also want to keep up because they need to, for example, recertify, pass their boards, keep up with CME. So for all of those reasons, doctors are constantly looking for ways to get more knowledge. We're lifelong learners. It's something you hear a lot when you're talking about doctors, this concept of lifelong learning. And I'm just appreciative that there's ways that allow me to get this information outside of just like sitting in a classroom or sitting in a conference.
I mean, I've talked to some physicians, maybe they're more proceduralists, but who are kind of like, hey, I did this training, I'm a doctor, kind of over this whole thing. I read a little bit, but I'm like 1 foot out the door. So I'm not really trying to learn about medicine in my free time, Well, as a patient, I hope that my doctor is a lifelong learner.
Yeah.
I hope. Yeah. And I'm going to interview him or her to see if they are, because if they're not, I don't want to talk to them anymore.
Yeah.
But it's kind of like what you said, though, is that patients are now more educated and are coming in saying, hey, doc, I want to talk about this. And if you don't know about it, I think like for a while you could get by if you wanted to, not that everybody does, but if you wanted to as a doc, you get by kind of like, I know more than my patients know. They're just not going to know about this really. Maybe they heard about something, but they're not going to know. So I have this like big information advantage. And obviously there's this big education advantage, quote unquote, or gap is the right way to say it. But
yeah,
as far as what's new, it's not quite like that. It's the information so out there. So you kind of have to keep up.
Right.
Basically.
Right. And just to respond to you, I am a surgeon, but urologic oncology, and the reason I chose urology is because it is not just a procedural field. I see my patients, I take care of them for a long time. I'm a little biased because I know you and I know your network. And so I think like, I'll pick on IR for a second. Interventional radiology, it's a little different. They don't actually manage chronic problems over time. They are such an important part of what we do in medicine, but they don't actually manage the patient and have that lifelong relationship with them. So it's a little different. You could get by as someone who's like an IR who is just getting consulted to do a certain procedure or exchange a tube or like, do a cath. Where I sit, it's like I need to keep up because I'm seeing that patient from the time they get their initial diagnosis to the third recurrence. And we're talking about cystectomy, right? So I meant to say initial diagnosis of non-muscle invasive bladder cancer, then they recur, then they progress to muscle invasive bladder cancer. Then we're talking about chemo, surgery. Like I'm the one having that conversation. So I don't have the ability to just check out. If today the standard of care is one thing, and in 20 years, the standard of care is something else, I need to be aware of that. And I think oncology in general, there's a lot of that. There's a lot of like constant evolution and discovery. And so these sorts of tools like podcasts, like ways to get, understand these new studies, they're really invaluable.
So I'm going to put you on the spot a little bit, okay?
Uh-oh.
You mentioned CME. I know you're only 3 years out. I want to tell me about something you've done for CME that you found educational.
When you go to conferences, you do learn a lot and you can obtain CME credit that way. This is like not really a hard question for me to answer because I'm in academics. So here's my bias. I get CME every Friday because I am faculty at a residency training program where we have grand rounds every Friday, and every Friday there's a CME session. So I learn something every day from my colleagues, from other experts in the field. Easy for me to get my CME. I have a lot of colleagues who are not at academic centers. It is really hard to get CME. And so those are the people who need to go to conferences, who need to do online CME activities.
So you don't partake in the online CME activities, really?
I don't because I don't need to. I get my CME every week at Grand Rounds. Or if I'm going to go to a conference, I go to a lot of conferences. I sometimes am speaking at them, right? But I'm also attending them because I have to be there to speak at the meeting. So I'll get my CME that way.
Like you swipe into a session and then you collect CME for having sat in a session.
Right. Exactly.
Okay.
Exactly.
Well, doctor, this has been informative. Anything that I didn't ask about that I should have?
We are in a bit of a revolution. And I say that because traditionally CME has been conferences, these online quizzes. I said I don't use them, but I know others do. The new generation is used to getting their content very differently. Podcasts, video, TikTok reels, Instagram posts. That is how they learn. And I'm not sure that our current med ed system has kept up at the pace that it should have, but I'm seeing a lot of activity now. And it's really fun to be a part of the team that is trying to revolutionize the way physicians learn. So, to anyone listening, I think it's important to recognize that the doctors of yesterday are not the doctors of tomorrow. And to be able to connect with this generation of physicians, you've got to meet them where they're at. And that is not in a conference room at some big meeting, that happens, or clicking through an online quiz to get your CME, or even reading a journal that comes to you in the mail. And so things are going to look really different. They already do, but they're just going to get more and more, advanced.
Well, we're glad to have you on the team too. Thanks for sharing this. I appreciate it. And I think our audience will too.
Awesome. Always a pleasure to chat with you, Anish.
Same. All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a BackTable hoodie in your future. If you have questions or comments, DM us. We're @_BackTableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.